Hello to you all. I'm Ben. So some of you will recognise me from on clinics as one of the clinical tutors at the University of Manchester. I'm also a specialty dentist at the Manchester Foundation Trust, and I've been asked to speak to you today about bridges. So bridges were the treatment of choice for many, many decades, the kind of principal treatment of choice. And recently, with the kind of advent of, or the increased popularity of implants, that has become the kind of key treatment approach for filling in spaces. But conventional bridgework still has a very strong place in dentistry. So what I'm going to do is I'm going to focus predominantly on conventional bridgework, and then I'm going to address briefly adhesive bridgework. And like I say, any questions along the way, you can either ask them at the end, or feel free to ask me them via Instagram. I've got my Instagram account here, Dr_Ben_BDS. And like I say, just feel free to message me any kind of dentally related questions at all. It doesn't have to necessarily be about bridges. Okay, so as I've said, the issue of filling in space. So bridges were the treatment of choice for many decades. And because of conventional bridges, let's say, were the kind of main treatment of choice for filling in spaces. Obviously, you do have things like dentures and things like that, but there has been a shift towards minimally invasive dentistry, so doing as minimal damage as you possibly can. And obviously, with conventional bridgework, you are prepping teeth, and there is a chance of obviously them losing vitality and things like that. And so there has also been an upskilling of many clinicians, and they're now going to placing implants. But like I say, there is still a space, a kind of position for bridgework in dentistry. So I'm just first going to go over the restoration of the edentulous area. So this is a classic OSCE station, actually, speaking about options for filling in spaces. And your kind of conventional options are your implant, which is kind of the gold standard option these days. It relies heavily on sound, bone levels, and favourable anatomy. And the good thing about them is that they ultimately have no destruction to adjacent teeth. The downside to them is obviously the cost, and you're looking at anywhere between £2,000 and £2,500 for an implant. And obviously there are limitations for anatomy. So, for example, if you've not got enough bone, you need to, with sinuses are very close, you might need to go through like sinus lift surgery and so on and so forth. So there's obviously costs involved with that. Then we've got our classic, bridges, conventional. As I've said, that they've worked very well. In this day and age, I'm finding that I'm seeing bridges that there were a lot of bridges placed in the 1980s and the 1990s, particularly, and I'm finding that a lot of them are still sound today, so they do work well. But the only thing is, as I've said, they are deleterious of tooth tissue on the abutment teeth, basically. So ultimately, what you're doing is you're drilling down teeth. Now, the conventional kind of thing that you're probably all taught at university is that there's about a 20% chance of loss of vitality for any crowned or bridged teeth. But actually, some research suggests that it's actually as high as 50%. So there's obviously issues with doing crowns and conventional bridgework. There is that risk. So as I've said, risk of loss of vitality. Caries is another big problem with bridgework and decementation. They are financially more affordable than implants. So I still offer bridgework as obviously a standard thing. Obviously, I offer all these different options. I personally don't place implants, but particularly in situations where in the NHS you find patients they may not want to go for the implant option, they may be financially out of their scope. So bridges are a very good option, and conventional bridges, they do come under that band 3 on the NHS, so they are affordable for patients. The only problem with conventional bridge work is when they fail, they tend to fail catastrophically, whether it's a root fracture or caries has got under the retainer, and ultimately they've had gross caries, and I'll show you a case of this a bit later. So usually it's very difficult to recover when conventional bridge work starts to fail. You can recover sometimes, but usually it's catastrophic. Then we've got adhesive bridge work. Now, as I've said, in this era of minimally invasive dentistry, people are more likely to go for, you know, adhesive bridge work because ultimately you're prepping in enamel. You know, you don't necessarily have to give LA to patients so that they like you for that. But the problem is they're limited by the length, the span length, where you know, you can be comfortable that you can reliably restore it and it's not going to debond or it's not going to fail. So typically one tooth usually you can replace. Now there are adhesive bridges that are big spans. You know, just on clinic the other week, I was speaking to one of my consultant colleagues about doing a potential adhesive bridge from upper 3 to upper 3, so canine to canine, on one of the students. And I personally would feel uncomfortable doing that in private practice because I'm just not 100% sure that you can take that full bite, you know, with the anterior guidance and things like that. I'd just be very, very wary of that. But the good thing about adhesive bridge work is that usually when they do fail, it's a case of just sticking them back on, basically. So that's good. Then we've got the old reliable dentures, removable option. They're far cheaper for patients. So in private practice, it might be anywhere between £500 and £800 for a denture. But the only issue with these is, you know, particularly in older patients, as their cognitive abilities decline, they may struggle to adapt to dentures. And finally, the other option that you've got is to do nothing. That is always an option. Now, as I said, this is kind of an OSCE station, certainly at Manchester, where I've seen it, where these are the kind of, is an OSCE station where they say, can you speak to this patient about potentially, you know, gap filling options? And this is the kind of thing you'd want to be talking about, basically. So as I've said, I've kind of already covered this. Why bridge work over implants? So some of the reasons: implants, 2,000 to 2,500 per unit. So they are much more expensive. Bridge work, you're looking at approximately £500 per unit. As you know, implants aren't available in primary care NHS. So, and the bridge work is available on band 3, which is about £256. But in private practice, you'd be looking at, say, £500 a unit for a bridge. So obviously a 3-unit bridge would be £1,500. Anatomy. So, for example, where, like I said, where the sinus floor is low and the patient doesn't want to go through sinus lift surgery. I was speaking to one of the students, I'm sure you know who you are, about that. I think your mum didn't want to go through sinus lifting surgery because, you know, there's the things of cost, there's the going through more and more surgeries. Some patients just don't want to go through all of that. And sometimes, you know, if you've got issues with anatomy, and providing that you've got healthy, viable teeth that can be used to hold a bridge, then grand, you can go for a bridge. Now, with the anatomy of conventional bridge work, I'm going to start, like I say, really basic, and then I'm going to go up to things like assessment of teeth. What are good abutments to use? What are good teeth that we can use? When we're looking at x-rays, we can go, yes, that's going to be a reliable, you know, pillar for a bridge. I'm also going to look at biomechanics briefly, so that's to do with flexing of bridges. But first and foremost, I'm going to start with the basic anatomy of conventional bridges. Now, this was a dual forceps extraction of a bridge that was failing, basically. Luckily enough, though, it was perio involved, so as you can see these hooks on the roots there, a bit of an effort, but I got it all out as one full unit, so I'm quite proud of that. So basically what you have is you've got your tooth, your abutment, which holds a retainer. Your retainer obviously holds your pontic, which is your false tooth, and then you've got your connectors in between holding the pontic to the retainers, basically. So that is your conventional fixed bridge, and I will move on a bit later to talking about things like fixed movable bridges. But pretty much that is the kind of general anatomy. So when I'm referring to abutment, think it's the tooth. When I'm talking about retainers, think it's the crown that sits on the tooth. And then obviously your pontics, your false tooth, and then you've got your connectors as well. So abutment. So how do we assess abutments for suitability? So first and foremost, vitality. They've got to be alive. You'll obviously use radiography. You'll use things like your ethyl chloride and things like that, just to check that this tooth is alive that you're planning to use. Endodontics and post. So I would always try and avoid posted teeth and any tooth that's been root canaled. Sometimes with posted teeth, the best option is actually to extract it and make the bridge longer, providing that your abutments are completely healthy and normal. And I'm going to move on now on to the crown to root ratio, root configuration, perio ligament support, and then we're going to talk a bit about occlusion and bridges. So I was always at university not really sure about what to look for on radiographs as to what would be a suitable abutment. And the first and foremost, and Schillenberg talks about this in his textbook, there are a few things in Schillenberg I'd be cautious about, but there are a few good points. So, and it gives you a kind of good map of how to kind of assess teeth when you're looking at radiographs. And the first and foremost thing is crown to root ratio. Ideally, you want a ratio of 2 to 3. So the amount of tooth that's in the bone is the 3 ratio, and the amount that's out is 2. Your kind of minimum is 1 to 1, but that's obviously not an absolute rule, but it gives you an idea when you're looking at your radiographs as to what would be kind of a suitable level of bone support. Obviously, you need to look at obviously perio and things like that as well. So I always say this is as a kind of broad thing is something to look for. With regards to your root configuration, obviously teeth that have got curved roots have kind of little curves in the apical areas. Teeth that have bulbosities at the end of the roots, they're all really good because they're good anchorage. It makes common sense, to be honest with you. And something, these are the things you should be kind of looking for. So you've got curvature in your apical third, you've got root bulbosities, you've got divergent roots, they're always positive. The more roots, the more perio support. It's like I say, common sense things. And the broader the root, it's better if you have broader roots buccolingually. And I'll explain that to you later. It's because bridges tend to come off in an anterior-posterior direction, and I'll explain why in a bit. But that's what you're looking for. Less favourable scenarios are, when you see those lower 7s with fused roots, they kind of got those conical roots. They're often very easy teeth to take out. So if you think about it on a bridge, it's less favourable. Not saying that you never do it, but obviously less favourable than this scenario here. Conical roots are also less favourable as well. So that's just something to look for. So like I say, first and foremost, we're looking at our crown to root ratio on the radiographs. We're looking at our root configuration, how that goes. And then finally, something else we look at, and this is something that Aunties Law, to put it simply, is outdated, and a lot of people say it's rubbish. But basically, in 1926, this law was kind of suggested, where they basically said the root surface of the abutment teeth should be equal to or greater than the root surface area you are replacing. Okay, so on this diagram down here, 1 and 3, the root surface should be equal, if not greater than the dotted area tooth that we are replacing. And this was followed religiously up until the 1970s, and even during the 1970s and 80s, they were still promoting this. And then there was a group in Linden Nyman, I think it was around 1975, 1976, and what they basically did was they took periodontally involved 2 canines on the lower, and they were periodontally involved, so they had bone loss, and they basically put 12 unit bridges. And I know the shock of that is 12 unit bridges, they are huge. And there's a lot of pressure on 2 canines that have reduced bone loss. But what they found was they really went at it with perio treatment. So scaling your root surface debridement, they really had these patients using, their cleaning was absolutely spotless. And what they found was they only had an 8% failure rate over 6 years. which is a sounding 12-unit bridges on 2 canines. So that kind of cast a lot of doubt over Aunties Law. We're saying, well, actually, yeah, you can consider Aunties Law, you know, it might make you feel more comfortable, but really it's not an absolute rule you must follow. It can still be used with cantilever design and kind of inform you of that side of things. But like I say, I always say consider Aunties Law. It's not something you should absolutely religiously follow. So, and this is the thing, a lot of people used to, and you'll see bridges like this where they double abutted or triple abutted, so they have double abutments or triple abutments either side because they're wanting to surpass the surface area of the tooth they're replacing, you know, or they want to at least meet it. Now, that's not a good idea at all, simply because if you think about it like this, if you're biting down on your pontic here, this is my art, I'm not the greatest artist in the world, but I think it kind of puts the point across a bit. So if you bite down here, essentially what's going to happen is it's going to put tensile forces on those double abutments, and it's going to create levering forces, which essentially will result in debonding of these end abutments. And once again, I'll show you a case on this later down the line where, you know, I've seen it where someone had triple abutted and the third abutment had debonded just in this way. Now, some people would argue that actually you could stick grooves into these teeth here and here to try and offset this issue, but really it shouldn't be done. So I would really avoid a double and triple abutting on any kind of bridge work you do, simply to meet a law that's actually being questioned. So with regards to abutments themselves with your preparation, so I'm going to go a bit about kind of crown preparations individually and then come on to the broader scope of bridge work. So ultimately, if you want your bridges to survive or have the best possible prognosis, first and foremost is you want supragingival margins, simply because you can then see, you can visually see that everything is sealed around that tooth, that it's absolutely sat down. Because one of the key failures of bridge work is caries getting under the retainer, basically. So being able to see those margins is the best possible thing. And really, you should be getting the patients to see hygienists on a regular basis. Each visit, really apply fluoride around the margins, and that will ultimately prevent, you know, your kind of caries infiltration in that particular area. The other thing as well is in terms of actual margins. Now, ceramics at dental school were taught, you know, with your ceramic preparations and things like that, to put a conventional shoulder margin. Shoulder margins are great for seating restorations, but they're not so good at sealing, if that makes sense. So what you can do is to improve the sealing capacity. One argument is you could stick a bevel. But the problem with a bevel then is that you've got unsupported porcelain, you've got very thin layers of porcelain, so that is a particular issue. So still really the gold standard in the posterior regions is metal ceramic, basically, because you can do almost a bevel or a shoulder bevel and have your metal that thin in those areas. Whereas if you did that with a full porcelain, you will have porcelain chipping off where you've got the bevel aspect. But what that does is it allows better sealing. So you've got the seating and you've got the sealing ability. So that's just something to think about. With regards to, everyone's heard about ferrule or ferrule. You need obviously your minimum height for that, just because you need that tooth tissue you know, for better resistance and retention form. And I know Dentinet had a talk on this a few weeks ago with like crown preparations and things like that. Now, how can we improve our resistance and retention form? Well, obviously total occlusal convergence, the ideal is 12 degrees. That's what they all say, 6 degrees on each axis. But in clinical reality, you're doing well if you get 20 degrees. Schillenberg himself assessed his own preps and they were 15 degree plus. So, and he's amazing at doing it. So you're doing well if you've got 20 degrees. Now, where you stick your slots and grooves obviously help with retention form. Now, crowns tend to come off, as I've said here, in a buccolingual direction. They do. So they tend to tip off. And that's why on, say, some of your metal ceramic crown preps, you place wings, mesial and distal. okay? Or you put slots and grooves, medial and distal on crown preparations. On the other hand, bridges tend to come off in an anterior-posterior direction, and I'll move on to that now. So basically, with bridge work, you should be putting grooves in your buccal and lingual aspect, okay, to resist that anterior-posterior tip. And as I put here, the question is, which abutment tends to de-cement more or easier, let's say, more commonly? And the answer is posterior. And I'm not sure if any of you have heard of this, but the reason why this happens is something called medial drift. So whenever you bite down on your back teeth, there is a push forward, okay, of all your teeth. You can't perceive it, but it does happen. And it happens in about 98% of cases. So what happens is, if you think about it, if you bite down on your anterior abutment just here, what it does is it pushes this tooth forward. Everything kind of gets pushed forward. And what happens as a result of that is your posterior abutment, it ends up creating a lever where it's rotating up and out, basically. So your posterior abutment is much more likely to de-cement. So on the other hand, biting down on your posterior abutment, as you bite down here, you've got medial drift happening, okay? But this force here, the medial drift of pushing this way, is offsetting the potential leverage of the anterior tooth. So ultimately, what you need to take home from this is medial drift results in the distal abutment tends to de-cement more. So if you're going to put resistance retention features, it's better to put it in the distal abutment. That's ultimately the clinical application to it. So if you're going to stick grooves in, and Paul Tipton talks a lot about this, and I would really advise anyone who is interested in this kind of stuff to actually go on his courses, see him talk. And he's written a number of really good papers on bridge work. And I would suggest, if anyone wants to know where they are, I can point you in the right direction. But he wrote a whole series of papers on different types of bridge work, and this is something he talks about. So essentially, like I say, put your grooves into the distal abutment. Obviously, there's nothing stopping you from putting them in both abutments. That's absolutely fine. But the key one is the distal abutment to put grooves in. So how do we gain further resistance and retention from? Crown lengthening or orthodontic extrusion are two ways to obviously increase the amount of tooth tissue that you can sit your crown on and increase retention and resistance for. With regards to pontics, okay, so you've got a number of designs. I'm sure you're all aware of these. So your ridge lap design, the problem with the ridge lap design is it's not the best for hygiene. You find a lot of plaque, food, debris, things like that get underneath here, and essentially it's the best, like it looks really good, but this is a particular issue. And the way that they tried to offset this was creating the modified ridge lap, where they basically took the palatal aspect of the pontic out, but the problem is it makes it thinner, so it's weaker ultimately. So the other one that we've got is the hygienic. The problem with the hygienic pontic is it looks terrible. It's great for obviously keeping it clean. You can get your floss under it and things like that, but ultimately it just has terrible aesthetics, so I wouldn't even consider that in the anterior region. This is a type of pontic you'd probably use in the posterior. The favoured one to use is an ovate, and this is the one that I would suggest most of you when you're filling in your prescriptions on clinics and things like that. That's the one that I would think you should be going for, simply because it has good aesthetics. It is cleansable, and it's got sufficient bulk to give it strength. Now, there is a trick that you can do when it comes to pontics. If you want a really good emergence profile, you can essentially do one of two things. The first is you can take a burr to the gums and remodel the gums. But the other thing you can ask your technicians to do is something called cast scoring, where basically what they do is, if you think about it, your biological width is 3 to 4 millimeters. What you can do is take a probe and measure how deep it goes down to bone. And essentially what your technician will do is, on the cast, they will cut out 1 millimeter of the ridge. So when they make the bridge and then you take it to the mouth and you put it in, it will cause blanching of the gums, but it will create a really nice emergence profile. So that's actually quite a good little trick to really get good aesthetics in the anterior regions. And the blanching does subside. It essentially almost like molds the gum to the the emergence profile and everything like that. So that works quite well. So consider cast scoring when you're doing particularly anterior bridges. With regards to occlusion and bridge design, so pontics should always be in light intercuspal interdigitation. If you've got, say, a pontic against a pontic, keep them slightly out of contact, and guidance should ideally be on abutment teeth if you've got to put them on abutment teeth. Now, sometimes you have to tell the lab, okay, can you transfer guidance to the upper right 3 if that's one of your abutment teeth, and the lab can do it. They're usually very good at that. A lot of people ask me, well, how do you actually go about doing that? Just ask the lab, that they can do it. So what happens if guidance can't be put onto the abutments and it has to be on pontics? So what you want is you want your guidance, if it's going to be on a pontic, on the most anterior pontic, because of the class 2 lever forces and things like that. So you want it on the anterior pontic. You want to avoid the middle pontic, okay, because there's all this idea of flexing and so on and so forth. And you want it closer to the abutment, so more anterior and as close to the abutments as possible if you're going to put guidance onto a pontic. So for example, this upper left 3 to upper left 7 bridge, so the worst to best pontic guidance. So the most anterior tooth is the upper left 5. That's the best one if you're going to put guidance onto something. You put it onto the upper left 5. Then the upper left 6. I know it's a bit further behind, but it's not the middle pontic. The worst pontic is the upper left 5 to go onto because that's the middle pontic. The best one is the upper left 4 because it's the most anterior. The upper left 6 obviously is a bit further behind, but it's still better than the middle pontic, which is the upper left 5. And also you want no non-working side interferences. So say if you're moving over to this side here and your bridge is on this side, you don't want it to hit as they move across to the working side, basically. And I've just said this, don't ever use posted teeth in bridge work because there's just a higher risk of root fracture. I do see bridges that are done with posts, but just sometimes it is honestly worth just taking the tooth out and actually just making a bigger bridge. Like I say, always tell a lab. So every laboratory prescription that you write, you tell them the type of occlusion you want. Light contacts on pontics, guidance on whichever abutment it is that you're wanting it on. And like I say, you just make sure you specify that kind of thing. So far, maximising success. Obviously, assessment, crown to root ratio gives you an idea. Root configuration, like I say, we're going for more of the curve, more apical curves. You're going more for or divergent root, more broader in the buccolingual direction. Periodontal support, consider Aunties Law, and I say consider because, like I say, there's still a lot of people say it's rubbish and things like that, but it kind of gives me a kind of framework to work around, so I like using it. Use ovate pontics. Like I say, they're very good for the aesthetics, but they're also cleansable. Resistance and retention form of abutments, 12 degree total occlusal convergence. Like I say, you're doing well if you've got 20 degrees. Place retentive grooves in the posterior abutment and stick them buccolingually. Okay, and that's to stop this mesial drift and this tipping out in the anterior posterior direction. Keep your margins subgingival, making sure that you're applying fluoride to the margins at each visit. And a guidance should be on abutments, ideally, but where you have to put it onto a pontic, it's the more anterior pontic that you're aiming for, and avoiding your middle pontics, basically. So that's just a few points there. So biomechanics of bridge work. Now, I've got to be honest, I don't really understand the maths behind this, but once again, it's a rule that is quoted in Schillenberg's Fundamentals of Fixed Prosthodontics books. So the longer the span of the bridge, the more flexing. Makes complete sense. So bending or deflection varies directly with the cube of the length and inversely with the cube of occlusal gingival thickness of the pontic. You'll have to read that back multiple times to try and get your head around it. But essentially what it means is if you have a 3-unit bridge with one pontic and it flexes by X amount, if you then add, you get a 4-unit bridge, 2 pontics added on, you've essentially doubled the span and it's actually resulting in 8 times deflection. 5-unit, 3 pontics, 27 times. 6-unit, 4 pontics, 64. So as you can see, there is a massive jump in the amount of flexing that happens at the bridge. So this is them bending, and there is the risk. What it does is it starts to kind of pull the abutments like this as it's flexing. Halving the connector also increases flexing by 8 times. So as you can see, so how can we offset this flexing issue? There are a number of things that you can ask the technician to do, or a number of things that you can do. The first is increase the thickness of your pontics and connectors. So the other reason I said pick an ovate pontic is it can provide 1 millimeter of extra connector length. So that makes a big difference. So another thing you can also do is, rather than having individual pontics that have little soldered connectors in between, you can make one big long pontic. You can use pink porcelain to make it look natural and things like that. And like I said before, you've got cast scoring as well, where essentially they take out 1 millimeter of the cast and they make it that, but that 1 millimeter reduces flexing. It's because it's increasing the overall thickness. So these are just a few things you can tell your technicians to do. Say increase occlusal reduction, that's a bit more of an aggressive approach to get, thicker amounts of material. And this is another good one, the use of a non-precious metal. So if things like your golds and things like that, they're very flexible and they move. So your non-precious metals, or even your semi-precious metals, they're a lot more rigid. So they're just a few things you can do to offset this problem of flexing, basically, of your bridge. So types of conventional bridges. Now, I'm going to kind of take the ethos of how Paul Tipton tends to teach, kind of how do we know which types of bridges to use for different clinical scenarios. So for any kind of short span, and I say short span, I say like a 3-unit bridge, in the kind of replacing one tooth, or where there's ambulation issues, you go with your fixed movable bridges. So there you go, primary design for posterior bridges replacing one tooth, or where there are ambulation issues, because essentially what you do is you have 2 components. I'll just move on to the next slide here. 2 components, as you can see here, and you have basically a lock and key, or a male and female part, basically. And what you do is you put your one abutment in first, and then the other one slots in place, so male, female. And what you do is you take off about 1/4 of a millimeter to 1/2 a millimeter just here, just at the bottom of the male component, because what that does is it allows that stress breaker element, and it allows it to kind of flex like this. Okay, so that is just something to consider. And like I say, Tipton tends to say, with your three unit bridges, kind of go with a fixed movable design. Now, the male and female element, you can either put it, obviously you've got this idea of, do you put it in distal abutment, or do you put it in your mesial abutment? And the answer is you put it in your mesial abutment. Why? Because of this idea of mesial drift again. And the reason why is, if you think about it, if you're biting down on your posterior abutment here, the mesial drift is pushing forward. It is pushing the male element, the key, into the female element, okay? Whereas if it was here on the distal abutment, as you bite down here, with the mesial drift of the anterior and things like that, there is a chance that you could end up pulling this key out of the lock. So you should always be putting it into your front abutment, basically. Now, what are the limitations of fixed movable design? They shouldn't be used routinely over long spans. And the reason for that is, if you've got a longer span, there is going to be more flexing. And the risk is, if you've got the stress breaker bouncing like this, there is a chance that the male element, or the key, could come out of the lock, basically. So that's the only issue with using fixed movable over long span. Don't use them in anterior regions because these bridges rely on axial force downwards. In the anterior regions, you've got kind of, different types of force, the kind of lateral forces and things like that. So they don't tend to work well, they just don't work in the anterior regions. The other issue is, for some people, is aesthetics. So the lock and key element is actually really expensive, but it almost looks like a little amalgam filling, and some people just don't like the idea of having that in their mouth. And the other thing you need to consider is, if you've got no opposing teeth, there is a chance that the distal abutment could start to over-erupt, and essentially that will lift the lock and key. It will lift the key out of the lock, basically, and it won't work. So why don't we use it, as I've just said, in longer spans? Simply because of the risk of bouncing and flexing. There are exemptions. So, for example, if you've got two abutments and one severely angled like this, you might want to go in, put your one component in, and then put your another component in. If you can't get parallelism on your preparation, or you're worried that you're going to expose the pulp, you can go in at different angles with a fixed movable bridge. But to be honest, that issue with angulation can be offset with things like copings, and that to re-angle the tooth so that you can then get, say, a fixed design, which is actually more suited to 5 or 6 unit bridges. So that is just something to be aware of with your fixed movable design. With regards to fixed bridges, as I've already said, we've gone across this. They're used more for your longer span. They're more rigid. There's going to be less flexing. But like I say, there is the issue sometimes with this angulation where you can use the fixed movable. The other thing you can do, like I say, is get the coping. And what you should be doing is you should be cementing the coping on permanently with permanent cement. But the bridge itself should only put on with temporary cement. It allows for quick removal if needed. So that is something, and you find that sometimes with implant bridges, you get your temporary cement to stick them on. As I've said, requires parallelism, I can't say that, or no undercuts, which, I'm sure when you're all practicing in clinical skills, that's what you're aiming for, is to get everything. So there's absolutely no undercuts with these fixed bridges. And then we've got our conventional cantilever. Conventional cantilever bridges, like I've said previously, avoid double abutments. Sometimes you can't help it if you're replacing a bridge and they've already got double abutments. Sometimes you've just got to go with it. The reason why we say no to double abutments, once again, is if you think about it, if you've got 2 retainers here, the middle, the most distal retainer here is going to act as a fulcrum. So as you bite down on the pondic here, there's going to be a tendency for this retainer to lever off, basically. And there is a risk of caries. But once again, as I said, this can be offset with grooves, basically. Particularly conventional cantilever bridge work, you can use that quite effectively at replacing, premolars. The one situation I've read where, and personally I've not done this, but with your double abutment, sometimes someone will want to replace, want a molar replacing, and you want to go with you've got no distal abutment. So what you can do is you can basically retain the 2, put a retainer on both the premolars to retain the molar. But like I said, there is this lever of force issue. Okay. So retainers, what are the best ones? So Roberts in 1970 looked at different retainer types and grouped them into major and minor retainers. So for example, a major retainer is one that is rigidly fixed. A minor has a movable element, basically, to it. So, like I said, your fixed bridges, they have 2 major retainers. Your fixed movable have a major and a minor retainer. And ultimately, the best kind of retainers are full crowns and 3/4 crowns, and they're always the best for majors. Whereas in minors, you can use your, your full crowns, your 3/4 crowns, and your onlays. Obviously, onlays suffer from this issue of there's not much crown height and resistance and retention forms. So if you can always get a crown on, then that's the best approach. So looking at some of these conventional bridge principles. So this was a guy who presented to me not so long ago, actually. And what he had was basically, he had triple abutment here. So upper right 3, upper right 2, upper right 1 were all retainers. Upper left 1, upper left 2 were pontics. Upper left 3 and upper left 4 were abutments. So straight away you can see that there's going to be an issue here. If you're biting down, increasingly here, there's going to be a lot of levering on this most distal abutment just here, the upper right 3. And sure enough, when I had, had taken the bridge off, that it was exactly the problem. So as I've said before, you bite on here, there is a risk of your double or triple abutted teeth from debonding, basically. And that's what happened with this upper right 3. As you can see here, took the bridge off, like I say, very old school bridge. It had gross caries underneath. It was also non-vital, so it needed root treatment as well. The other abutments were fine. This was okay, this was okay, this was okay, and the 4 and the 5. They were all okay. We had, luckily enough, I could just about get a 3mm ferrule, but I decided to root treat this and put a post in there and treat that. And basically what I decided to do was this tooth here, post crown after root treatment, single crown on this tooth here, single abutment here, pontic, pontic, single abutment here, crown, crown. Okay, so I wasn't double or triple abutting. And I'll just go through. So this was my overall treatment plan. So root treat upper right 3 with post, utilise 3mm, crown the upper right 2, single abutment either side, conventional bridge upper right 1 to upper left 3, crown upper left 4 and 5, composite veneers upper right 4 and 5, porcelain veneers lower left 4 to lower right 4, composite veneers lower left 5, lower right 5. The reason why you went with composite on the back teeth here is more just to do with cost, to be honest with you. But that was something he wanted to go with. So. And this was the bridge design. So some of you might have seen me, I've put this up on Instagram and things like that. So as we can see, we've used ovate pontics here. We've thickened the connector length here, obviously to offset any issues with regards to, flexing. I've said I've fulfilled Aunties Law. Like I say, it's just a consideration. It just makes me feel more comfortable, even though, like I say, a lot of research contests it. So if you think about it, the upper left 1 and the upper right 3, this was taken from Schillingberg's book, basically. As you can see, the abutment surface area is greater than what the pontics would be. So I know, in my mind, I feel that's better. The crown to root ratio was over 2 to 3, so that was fine. Like I say, and I had good preparation height, and I did full coronal coverage just to, it's obviously in the anterior region, so you have to go with that, but it's best for, resistance and retention form. So that's what I did. Now, I thought, oh, this is going to be a nice case and everything. I wanted it to look natural and everything like that, but he wanted the whitest teeth we possibly could get. And we actually had to import the block to make this from Germany because it was very, very white. So this was the end result, too white for me, in all honesty. Like I didn't like how bright they were, but ultimately he was really happy. We had our veneers on the lower, we had our bridges, we had our crowns. The other thing as well, just to say, with the post crown on the upper right 3, I did tell the lab to keep that out of guidance completely, because obviously if you've got canine guidance on a posted tooth, there's going to be a much higher risk of fracture. So I literally said to them, transfer guidance onto, I said to them the upper right 4, because I felt like that was the most solid and everything like that. And I didn't really kind of want to put it onto the abutments and things, you know, that. So that's basically what I did. So like I say, there was no guidance on the post crown here, and everything else was okay. So overall conventional bridge work. So always assess your root ratio, gives you an idea. Root morphology, consider Aunties Law, consider the span you wish to restore. So it's the type of bridge you want to do. So 3 units, go with, you know, fixed movable is a safe option. 5, 6 units, you're looking fixed. Ensure good retention and resistance form. Place your grooves in the distal abutments. Use full crowns to maximise your resistance and retention form. Keep your margins supragingival because they're cleansable, they're visible. You can, at each checkup you can check them basically. In the anterior regions with your margins, you might need to make them just juxtagingival, so, or equigingival, obviously because you want a good aesthetic look on your abutments, but at the same time you want to be able to probe them and things like that just to check them. Routine hygiene appointments, fluoride applications. Prevent flexing by thickening your pontics and your connectors. Ovates, as I've said, are good for it. Don't double or triple abut. And guidance on your abutments. Avoid pontics, keep light contacts, and if you're having to put them onto pontics, anterior, and avoid the middle pontic basically. So adhesive bridge work. Once again, in this era of minimally invasive dentistry, it's a good option if you're trying to replace single spans and you know single teeth, shorter dental spaces. You want to stay minimally invasive, and your preparations are being kept to enamel, and you don't need LA. Now, obviously, bond relies on enamel, so obviously you have to assess the individual abutment teeth to make sure there is sufficient amounts. Now, survival rates, a lot of people say about resin bridge work saying that they don't last long and things like that, but these groups looked at, 5 years isn't really very long, but 87.7% success rate at 5 years is good going. 80% at 10 years in this group based in Bristol. Posteriors were more likely to fail and anteriors, fixed more likely to fail than cantilevers. Old restoration bonding, so when you're doing these adhesive bridge work, try not to put them on restorations. If you're going to do that, you should resurface the restoration. There was a good article, I think it was in the July-August 2016 edition of Dental Update. Have a look at it. That's a good read on designing resin bridge work. And I'd like to say they summarise all the research behind it, but they do work quite well, these adhesive bridges. Now, there is this thing of, do you no prep or prep? Now, if you take your conventional preps and you've got your grooves on the cingulum, that provides support, axial support. Grooves, your medial and distal when it comes to adhesive bridge work are good for resistance form. So I tend to go more with preps to do just to, for the resistance and retention form. But, it's really up to you. So as I've said, enamel is essential. Old restorations, if they can't be avoided, they should be replaced or resurfaced. Wing coverage, as I've said in the posteriors, if you do want to use them in the posterior region, 180 degree extending onto the occlusal surface, because me and one of my students the other day were doing bridge work, resin retained bridge work, and this is the kind of way we went. We put rest seats, mesial and distal. Anteriors, full palatal or lingual up onto the incital edge, and you've got those little incital edge locators that you can use to position it and sit it on, and you can cut that off. Retainer thickness, make sure you've got a minimum of 0.7 millimeters for sufficient rigidity. And like I say, don't double abut. Try not to go with double wings as well. Don't do it, because what will happen is one of the wings will de-cement, and as you all know, caries will get in underneath and it's very difficult to tell. Now, as I've said, I was speaking to one of the consultants a few weeks ago about using fixed on either side for long spans. I personally wouldn't feel comfortable with that, using adhesive two wings, but people still do it. When it comes to occlusion, like I say, once again, your contacts are on abutments and retainers rather than the pontic. The pontic should have light contact, very much similar to conventional bridgework. And that's pretty much it with regards to like kind of your basics on kind of design and of conventional and a bit on adhesive bridgework. But like I say, it's kind of logical, and it gives you a kind of framework from which you can work from. Like I say, if anyone wants any of these slides, I'm more than happy to send them over. If anyone has questions, I'm more than happy to answer them. You can either email me or you can get me on Instagram, whichever is easiest, basically. But yeah, I think that's me.